One of the things that we've seen in the last few years is that there's agents that I think all of us thought were going to be successful in the phase 3 setting and be the way that we were treating patients now, whether that be IDO1 inhibition, using Canakinumab, the IL-1 beta antibody, TGF-β blockade. There's a BIN-alpha is a TGF-β PD-L1 bispecific, and they all looked very promising in early stage trials. But unfortunately, they went to phase 3 trials that were not biomarker informed. And we also don't really know how any of these drugs work in humans in vivo. And because of that, we've seen phase 3 failure after failure after failure, which really is, it's obviously a lot of resources that are lost when you do that. But most importantly, it's a lot of patients' time and effort. So, many of these trials enroll 1,000 patients, and we're just seeing, Kaplan-Meier curves lie on top of each other. So I think that, what I'm going to be discussing in my talk on biomarkers is how we really, during the phase 1, even first in human dose escalation setting, we should be getting high quality pre-treatment and on-treatment biopsies and lots of blood, and we should be studying even that early on how these drugs are working, because if we can define the mechanism of action of these drugs in humans, we study it in mice, but we are not inbred rodents. So if we can define it in humans early on, we can better understand how to combine these drugs, or potentially how to sequence them, or in what setting we should be using them, whether it be the perioperative setting, the metastatic setting, or maybe the immunoprevention setting, which is probably where Canakinumab would have the greatest benefit, even though we're not seeing it work in the metastatic setting for lung cancer.